So, chapter 13 is neurodevelopmental and neurocognitive disorders. So, when it comes to developmental psychopathology, we have to consider what's normal versus abnormal development. So, we have to look at the age and the environment of a child to know if it's considered normal or abnormal. When it comes to developmental psychopathology, we have to study how disorders arise and how they change over time, and what's disruption of early skills, um, and how they could affect later development. So, when it comes to neurodevelopmental disorders, these are going to be things that are first diagnosed in infancy, childhood, or adolescence, and they can include ADHD, a learning disorder, autism, an intellectual disability, or a communication and motor disorder. And so, first, we're going to start with ADHD, or attention deficit hyperactivity disorder, which involves inattention, overactivity, and impulsivity. Those are the central features of the disorder. It can also be associated with impairments in behavioral, cognitive, and social and academic areas of living. When it comes to the DSM, there are some symptom types which involve inattention that's present, hyperactivity and impulsivity that's present, or a combination of each. So, oftentimes when people think of ADHD, they only think of the hyperactive part, and they don't realize that there are some children who are diagnosed with ADHD who are not hyperactive. So, here are the DSM criteria for ADHD that involve inattention. Here are the DSM criteria that involve hyperactivity and impulsivity. Here are those remaining criteria. Now let's talk about some facts and statistics. When it comes to prevalence rates, ADHD only occurs in about 5% of school age children. If you think from a societal standpoint, that number seems to be much larger because it's so prominent in our society. Symptoms are generally present around age 3 or 4. There might not be noticed until a child is school age. And it's hard to know before a child is school age, because if a child is only in one environment, it's hard to know if they'll be different when they're away from their parents. And children typically are different, not in the presence of their parents. Children with ADHD tend to have those similar problems also as adults. There are some gender differences, with boys outnumbering girls 3 to 1 when it comes to the diagnosis of ADHD. Culture can also play a role because it's most commonly diagnosed in the United States, but it is fairly consistent worldwide. When it comes to genetic components, we do know that ADHD tends to run in families. We also know that there's the dopamine transporter gene that has been implicated, and that there are some ADHD medications that work towards inhibiting that dopamine transporter gene, that DAT1 gene, so that those symptoms won't persist. From a neurobiological standpoint, there's usually a smaller brain volume and inactivity of the frontal cortex and basal ganglia of children who have ADHD, or people with ADHD, and there's some abnormal frontal lobe development and functioning. So, of course, the frontal lobe is naturally underdeveloped, but those problems related to development continue to persist with those who have ADHD throughout their lifespan. We know that also toxins could play a role. Food additives like dye, like red dye, is a big one, and pesticides could play a small role in hyperactive and impulsive behavior. Maternal smoking during pregnancy could also increase the risk of developing ADHD. There are a few psychosocial contributions as well. Children with ADHD are often viewed negatively by others. They are often receive negative feedback from peers and adults, and that can lead to social isolation and low self-esteem. When it comes to how we treat ADHD, oftentimes biological treatments are the first level of defense to reduce those impulsive and hyperactive symptoms and to improve those levels of attention. So, stimulant medications such as Adderall and Ritalin are often given. Those are prescribed to over 4 million American children, and they can increase a risk for later substance abuse. If a child has been known to take medication for their whole life, they could be used to taking medication. There are a few other medications that are not as effective um, in reducing those symptoms of hyperactivity. We know that genes can affect an individual's response to meds. So sometimes there's trial and error. And oftentimes, children with ADHD often have to have their medications adjusted. But by taking ADHD medications, it can improve compliance, decrease negative behaviors, um, positively impact their learning and academics. And the benefits of these drugs are not lasting if those drugs are discontinued. And unfortunately, sometimes parents will want to give their child a break on weekends or summers from taking their medications. And when they do that, they'll see an escalation of those behaviors that were discontinued. We can also have combined therapy and medication. So, behavioral treatments, which can reinforce things and increase appropriate behaviors while decreasing inappropriate behaviors. Also, having some parental training. Some combined biopsychosocial treatments can also be helpful. Our next disorder that we're going to discuss are learning disorders. And this occurs when a person has academic problems in reading and mathematics or writing. Their performance, it can be substantially below expected levels based on their age. And those problems have to persist for more than 6 months in order to have some type of intervention. So, impairment in reading may include word reading accuracy problems, reading rate or fluency problems, and reading comprehension problems. When it comes to written expression, it could be difficulties with spelling accuracy, grammar, punctuation accuracy, and clarity and organization of written expression. When it comes to mathematics, it could be impairment in numbers, arithmetic facts, calculation, or math reasoning. And just because a person might have a reading learning disorder doesn't mean that they also have a writing or a math or vice versa. They're not all inclusive, they can be separate. And here are the DSM criteria for a specific learning disorder. Oftentimes, most learning disorders will be diagnosed through the school system because that's where the problem will be found. So, when it comes to those statistics related to learning disorders, about 6 million children have been diagnosed in the United States. The highest rate of diagnosis is in wealthier regions, but children with low SES are also likely to have difficulties. So, if we think about it, a lot of those parents in wealthier regions are probably seeking the treatment more often than people who don't have the resources. Reading difficulties are most common and generally affect between 4 and 10% of the general population. And school experience tends to be generally negative, especially for those who have learning disabilities. If we look at this chart, we can see that there's an uneven distribution of learning disabilities when it comes to states and in the United States. Again, with wealthier states tending to have the highest prevalence rates of learning disabilities. From a biological and psychosocial perspective, Learning disorders tend to run in families, but specific difficulties are not inherited. There's evidence for subtle neurological difficulties that has also been mounting. There are also some psychosocial contributions that are likely important. When it comes to treating specific learning disorders, it requires intense educational interventions. So there has to be remediation of basic processing problems, improvement of cognitive skills, targeting skills to compensate for problem areas, and having that data to support those behavioral educational interventions are key. So reaching out to teachers and having those work samples are very important. The next disorder we're going to discuss is autism spectrum disorder. And this occurs when there's problems with language, socialization, and cognition. These problems can expand in many different life areas. And then the two main areas of impairment tend to be with social interaction and communication. About 25% of people with autism spectrum disorder don't acquire effective speech. They could have restricted, repetitive patterns of behavior, interest, and activities because there's a need for them to maintain sameness and high levels of consistency. So, eating the same foods, engaging in the same routines and behaviors are prominent. Autism spectrum disorder is a new label in the DSM. It encompasses several different disorders, which were previously called pervasive developmental disorders. So it could include autistic disorder, Asperger's disorder, childhood disintegrative disorder, and then also Rett syndrome, which were in previous DSMs. So now we look at it on a spectrum. Here are the DSM criteria for autism spectrum disorders. Lots of criteria because now we've added a spectrum of how it can be presented. So when we look at prevalence rates, about 1 in 50 school-age children meet the criteria for autism spectrum disorder. It's most commonly diagnosed in males, and about 38% of individuals with autism spectrum disorder might also have an intellectual disability, and this disorder does occur worldwide. From a historical standpoint, many parents often blame themselves and believe they failed at parenting. Um, when the disorder was first looked at, it was often thought that perfectionistic and cold and aloof parents were involved. Parents from high socioeconomic status and higher IQs were involved. We know that that's really not the cause, that parents can't really cause autistic spectrum disorders. Having a lack of self awareness and behavioral uh, correlates have also been sort of a historical way we view the disorder, where people with autism spectrum disorder often engaged in immediate, delayed, or mitigated speech and self interest behaviors. From a biological standpoint, we know that there's a genetic component. If one child has autism, there's a chance of having a second child with autism as well. There are numerous genes that also could be involved. We know that oxytocin is a receptor in the genes that could play a role. And one of the biggest factors that have been found is generally older parents are waiting to an older age to have children could be associated with increased risk of autism spectrum disorders. There are also some neurobiological influences, such as the amygdala, which is involved in our emotional expressions. They tend to be larger at birth, which could increase the levels of fear and anxiety. Having elevated cortisol levels, which is the stress hormone, and also having neuronal damage in the amygdala could be caused by high levels of stress, and having lower levels of oxytocin could also impact the development of autism spectrum disorders. At one point, people thought that vaccines could increase the risk of autism spectrum disorders, but I want to dispel that myth. Vaccinations do not increase the risk of autism. And the reason people believe that is because there was mercury in some vaccines that they thought increased those levels, but there's been a number of studies that have disputed that, and we don't want to perpetuate that thing. There's more risk in not vaccinating than in vaccinating. When it comes to psychosocial treatments, there are a few behavioral things we can do, such as skill building, reducing problem behaviors, having communication and language training, increasing levels of socialization, and naturalistic teaching strategies. Early intervention is going to be critical. So it's very important for us to normalize the functioning of the developing brain and for parents to really get on board to get their children the best treatment. Biological treatments, such as medication, has very little positive impact on functioning. There are some drugs that can decrease agitation, such as tranquilizers or SSRIs, and there's generally good prognosis with that. People with autism spectrum disorders generally have high IQs and good language abilities. And there's also some integrated treatments that might be necessary, which is the preferred model, such as something that's multidimensional and comprehensive. So children are often referred in school to special education services to help them with their communication issues, some medication usage, and families who are given support. When people with autism spectrum disorders get older, they just focus on integrating into community and being more independent. Another disorder we're going to discuss is an intellectual disability. And this occurs when a person has below average intellectual and adaptive functioning, which generally is first present in childhood. It can range in how it's presented. And we call it intellectual disability now in the DSM-5. It was previously known as mental retardation, and it generally involves an IQ of below 70. So, when we think of an IQ that's between 70 and 75, that could also be related to an intellectual disability. Or, for some people, that's more borderline intellectual functioning as well. The DSM identifies difficulties in 3 dimensions: conceptual, social, and practical skills. These things tend to be devalued by society. So conceptual skills might be having, those academic difficulties, whereas social difficulties involve relationships and friendships, and those practical skills have to do with the inability to care for oneself. Here are those DSM criteria for intellectual disabilities. And then also, we can look at some other ways of classifying intellectual disabilities. For example, the American Association of Intellectual and Developmental Disabilities says that an intellectual disability is based on assistance required. So they look at it in terms of intermittent, limited, extensive, and pervasive intellectual disabilities, and they keep the emphasis on the level of assistance that's needed. When it comes to statistics, about 2% of the general population has an intellectual disability. 9 in 10 people with intellectual disabilities have mild impairment. So their IQ is between 50 and 70. The course of it is chronic because it doesn't really change. There's highly variable individual prognosis. So it really just depends on the skills the person learns, how much they'll be able to function. When it comes to what causes an intellectual disability, there are a lot of different known causes. There could be environmental causes such as neglect, lack of nutrition, issues with prenatal development, perinatal problems that occur during delivery, and then also postnatal causes. Fetal alcohol syndrome, being exposed to illnesses inside the womb, not getting enough oxygen during birth, experiencing malnutrition, head injuries, or child abuse could impact intellectual capacity as well. We know that genetics also plays a role. Chromosomal disorders such as Down syndrome, having multiple genetic mutations or a single gene could also be responsible. For most cases, there's not really an identified cause. We also have a couple of other genetic influences that could occur. Things like cerebral palsy, self-interest behaviors, or any type of allele on the X chromosome, which could affect males. PKU could also be a cause, which is found in some foods. There's many tests that occur now at birth to detect the presence of the inability to break down PKU, to let parents know if that would be a possibility. When it comes to Down syndrome, it's the most common chromosomal cause of intellectual disabilities. It's often called trisomy 21, and there's often distinctive physical symptoms that are also present. There's higher risk of developing Down syndrome with the increased maternal age. This can be detectable with prenatal tests and amniocentesis, mother's blood test, but the test won't show the severity of the disorder. So about 1 in 4 mothers often elect to terminate their pregnancy if Down syndrome is present. Fragile X syndrome can involve a learning disability, symptoms of hyperactivity, a short attention span, speech issues, gaze avoidance. It also tends to affect males. Women with Fragile X have mild syndromes because remember, those females have another X chromosome to help balance out if there's any deficits, but males don't. We could also have some cultural factors that could cause an intellectual disability. It could be due to social environmental factors, abuse, neglect, social deprivation, in combination with biological factors. You can see from the chart that the levels of Down syndrome tend to increase as the age of the mother increases. So when it comes to treating an intellectual disability, there could be a treatment that's similar to autism. If there's severe intellectual disability, if there's mild intellectual disability, you would treat it more like you treat a learning disorder. The goals are similar no matter the cause. There's lots of behavioral interventions, so teaching of basic skills, social skills, and then also practical skills. Common goals might be to participate in your community, to benefit from education, to hold a job, to build meaningful relationships so that those skills of independence can be developed. So when it comes to preventing neurodevelopmental disorders, the efforts are focused on those early stages and early intervention. So that's why the Head Start program was developed in schools to identify children early for those educational and those medical and those social support issues. And then also genetic screening is used to have those early detection. So to summarize, neurodevelopmental disorders encompass a wide range of disorders with varying severity. They may be caused by genetic or environmental factors, or they may not have a specific cause. Treatment is always going to focus on the mitigating functional impairment. When it comes to neurocognitive disorders, these are disorders that affect learning, memory, and consciousness. These are things that may be developed later in life. There are 3 classes of cognitive disorders. They are things such as delirium, which involves the temporary confusion and disorientation. Major or mild cognitive disorder, which is marked by a broad cognitive deterioration. And amnestic disorders, which involve memory dysfunctions. So there's been a shifting perspective in the DSM when it comes to how we look at neurocognitive disorders. There's been a shift from organic mental disorders to cognitive disorders. These involve broad impairments in cognitive function and profound changes in behavior and personality. So when it comes to delirium, we have to think about how impaired consciousness and cognition is. It tends to develop rapidly over several hours or days. It involves appearing confused, disoriented, or inattentive, and can be marked by memory and language deficits. Delirium tends to affect about 20% of adults, and oftentimes in acute care facilities or ERs. They're most prominent in certain populations, so older adults, those undergoing medical procedures, and AIDS and cancer patients. Full recovery often occurs within several weeks. Here are the DSM criteria for delirium. And we also can have some medical conditions that are related to delirium. First, we could have dementia, which is 50% of those cases of temporary delirium. Drug intoxication, poisons, withdrawal from drugs could cause a person to be delirious. Having an infection is very common with UTIs, especially in elderly populations. Having a head injury or other form of brain trauma. Having sleep deprivation, immobility, or excessive stress could also lead to delirium. So when we want to treat and prevent delirium, we want to look at precipitating medical problems and some psychosocial interventions. So comfort, coping strategies, inclusion of the patient in their treatment decisions. And if we want to prevent episodes of delirium, we want to address those proper medical care for illnesses and proper use of therapeutic drugs so that those dosages are followed appropriately. We also have major and mild neurocognitive disorders, and these are often involved when people have dementia. It involves gradual deterioration of brain functioning, decreased judgment and memory, deterioration in language and advanced cognitive processes, and can have many causes and may be irreversible. So major neurocognitive disorder is a new term in the DSM that we use to describe dementia. And this involves an individual when they have mild neurocognitive disorder. This is the early stage of cognitive decline when they have an inability to function independently with some accommodations. So if they're given lists, they can still function. But for a major neurocognitive disorder, this involves one or more cognitive deficits that represent a decrease from previous functioning, substantiated by clinical assessment, and they interfere with daily independent activities. So this is when a person can no longer really live on their own because of their memory issues. Here are the DSM criteria for a major neurocognitive disorder. And here are those criteria for mild neurocognitive disorder. When it's mild, they can still function if they have lists, directions to follow. And when it comes to major neurocognitive disorder, in the initial stages, this involves memory and visual spatial skills impairment. There might be some facial agnosia, so the inability to recognize familiar faces, and delusions, apathy, depression, agitation, or aggression. In the later stages, there might be decreased cognitive functioning, a need for total support to carry out day-to-day activities, and increased risk for early death due to inactivity and onset of other illnesses. We also have some DSM-5 types of major and mild neurocognitive disorders. And you can see them all listed. There are tons of them. When it comes to neurocognitive disorder due to Alzheimer's disease, this accounts for nearly half of all neurocognitive disorders. This typically involves gradually and steady development of memory issues, orientation, judgment, and reasoning problems. It may also involve those symptoms of agitation, confusion, combativeness, depression, and anxiety. There could be a range of cognitive deficits involving Alzheimer's disorder. There could be aphasia, which is difficulty with language, apraxia, which is impaired motor functioning, agnosia, which is failure to recognize objects, and difficulty with planning, organizing, sequencing, and abstracting information. This disorder can have a negative impact on social and occupational functioning as well because of the inability to do those things that relate to cognitive functioning. Some facts and statistics involving Alzheimer's disease is that the deterioration is slow during the early and latter stages. It could be rapid during the middle stages, and the average survival time is about 8 years because it is a progressive degenerative disorder, and generally the onset is around the 60s or 70s. There's a greater prevalence in low education groups of Alzheimer's disease. It's thought to reflect protective elements of high education and more cognitive flexibility. Better educated people will eventually decline more rapidly if they develop Alzheimer's disease. Women are slightly at higher risk. There's prevalence rates that are thought to be low in some ethnic groups, and that's likely to be a reflection of education and who seeks care, not really a true difference. Vascular neurocognitive disorder involves a blockage or damage to blood vessels. It's the second leading cause of cognitive disorders after Alzheimer's disease. Its onset is often sudden due to stroke, and there could be patterns of impairment which are variable and can require some formal care in later stages. So the symptoms are going to be similar to dementia. It involves neurological signs of brain tissue damage. It's typically present in about 1.5% of people between 70 and 75 and 15% of people over age 80. It can be slightly higher in men. Other causes of neurocognitive disorders might be a head trauma, which is an accident that can happen that can cause memory loss. May be found in a lot of athletes who experience repeated head traumas, like football players and boxers. Parkinson's disease is another degenerative brain disorder that tends to affect about 1 in 1,000 people. It can involve motor problems due to damage to dopamine pathways. And about 75% of people with Parkinson's disease have a 10-year survival rate. HIV-1 can also cause some neurological impairments and dementia, cognitive slowness, impaired attention and forgetfulness, as well as apathy and social withdrawal. Pick's disease is a very rare neurological condition, and it's very similar to dementia, but occurs around 40 or 50. And there's not really a lot of research about it, so it's very extremely rare disorder. Prion disease is a disorder of proteins in the brain that reproduce and cause damage. It tends to affect about 1 in 1,000,000 people, kind of like mad cow disease. There can also be substance induced neurocognitive disorder, which results from prolonged use of substances and a poor diet. These drugs can lead to symptoms of dementia, and they can result in brain damage that goes beyond a normal level of intoxication and lead to symptoms of Alzheimer's. We also have Huntington's disease, which is a genetic autosomal dominant disorder, which manifests itself usually later in life. Generally affects about between 20 and 80% of people with neurocognitive disorders. So when it comes to some of the causes of these neurocognitive disorders, especially Alzheimer's disease, we know that there are some neurofiber tangles that could play a role, some plaques that exist in the brain, and different atrophy in various areas of the brain as well. So those cells are just start to die. We know that genetics can also play a role um, as well when it comes to developing Alzheimer's disease. There are multiple genes that are involved in Alzheimer's disorders, and genes for chromosomes 21, 19, 14, and 12 have been found to be prominent with the risk of Alzheimer's disease, with chromosome 14 being associated with early onset Alzheimer's and chromosome 19 being associated with late onset Alzheimer's disease. When it comes to some psychosocial factors, we don't know what causes dementia. It could be lifestyle factors, drugs, diet, exercise, stress, also some cultural factors, and as well as psychosocial factors related to education, coping skills, and social support. When it comes to treating these disorders, there are not a lot of treatments that are going to reverse the course of the disorder. They can just kind of slow the progression, but not stop it. So there's lots of future studies that are being done to look at other things that can help slow the progression as well. There are also some drugs that can treat different cognitive deficits that have long-term effects that are just not well determined as of yet. So when it comes to psychosocial treatments, you want to enhance the lives of patients and their families because it can be very isolating to experience these memory issues and not have family members visit because you don't remember them anymore. Teaching some memory enhancement devices to use those devices can also be helpful, and helping caregivers deal with stress the stress associated with having a family member suffering from a neurocognitive disorder can also be helpful. When it comes to prevention, using anti-inflammatory medication in adults, reducing those risks can help. Controlling blood pressure and not smoking and having a more active lifestyle could also play a role. Increasing safety behaviors to reduce head traumas and reducing exposure to neurotoxins and the use of drugs can also be helpful. So to summarize, for neurocognitive disorders, these are going to be disorders that span a range of deficits involving attention, memory, language, and motor behaviors. They can involve aging, medical conditions, drug use, and environmental factors. Most result in progressive deterioration of functioning, and there are not a lot of treatments that can reverse damage and deficits. So I know that was a lot of information, but I hope it gives you a better understanding of neurodevelopmental and neurocognitive disorders.